Hi, everyone. Thanks for joining today's webinar. This is the second of a 5-webinar series focusing on 3D imaging. Today's webinar focuses on determining which of your patients need a 3D image. My name is Adam, Content Marketing Specialist with Henry Schein, and I'll be your moderator. If at any point during the presentation you have questions, please type them into the Q&A section of your control panel, and we will try to cover as many questions as possible at the end of the webinar. Please make sure that your volume is up and any large computer applications are closed to ensure a smooth connection. This webinar is sponsored by Henry Schein Dental and Cavo Imaging. No CE credit is being offered for viewing the on-demand version of this webinar. Our speaker today is Dr. Glenn Krieger. Dr. Krieger has presented to thousands of dentists in North America and was named top clinician in continuing education by Dentistry Today 10 times. We are excited to have him presenting for us today. Thanks for being with us, Dr. Krieger. Over to you.
Hey, thank you very much. And I hope everybody's having a great day. I see we've got a ton of people in the room, which seems to be the norm for us nowadays. And I promise you, in the next hour, we should have a great time. Hopefully share a lot, learn a lot. And if there are questions, please ask them away. Our moderator, Adam, will certainly get them to us. And so today's topic is, which of my patients need a 3D image? And I'm going to go through my story a little bit about what I was in terms of a dentist, orthodontist, relative to CBCT and lateral cephs or Panorex, and how did I end up here, if you will. And there are some great resources out there for people you can meet up with. I know there's more people in this series who are going to give you some other great information. So my goal today is really just to answer this question: which of my patients needs a 3D image? So let's first say thank you to Cavo Imaging and Henry Schein Dental for putting this on. Without them, this wouldn't be happening. And I want to give some disclosures real quickly to everybody. I am being compensated for this lecture. I have no financial interest in Cavo Imaging or in Henry Schein Dental. And many of the images here and videos have been edited for global changes. Now, what does that mean? Many of you have probably seen me speak on clinical photography. We can change anything that affects the entire broad image, but what we can't do is make one section look better or different just to sort of enhance or change the outcome. So things have been edited for light, dark, contrast, and what have you, but obviously nothing's being done to change the image per se to give you a false sense of what's going on. I'm known by many people also out there as the person who started the Orthopreneurs Facebook group. If you are not a member of this group and you are an orthodontist, I encourage you to please go onto Facebook and sign up. The only requirement is that you're an orthodontist or an orthodontic resident. If you've been accepted into orthodontic residency, that counts as well. But it's not for team members, unfortunately, and it's not for companies or general dentists. I apologize, but it is a place where we do talk about all of the issues related to orthodontic practice and how to become better, lower stress, more productive. So please go check it out. Currently, I gave a lecture in Paris last year. We were at 89 countries. But now we've got 90. So we are really international, and it's a great place for us to share a lot of the things that we're talking about, including CBCT and normal practice issues. So please feel free to go there. Now, if anybody here, and I suspect all of you, are online in Facebook groups of some sort or another, you'll often find that people will talk about things that can be somewhat polarizing, and all of a sudden a kind of a mob mentality takes over. And oftentimes CBCT or airway dentistry or any number of things create this mob-like mentality. And so, you know, Descartes said it best that an optimist may see a light where there is none, but why must a pessimist always run to blow it out? And isn't that so true, that it's so easy to point something out that's good and then everybody jumps on it? So today I'm just asking you, see things from a different perspective. That's all I'm asking. No matter what you think you know about CBCT, its benefits, its downsides, good and bad, I'm just asking you to come in with a blank slate, open up your mind to the possibilities, and let's talk about everything that we see openly and honestly, because at the end of the day, nobody wants to deceive anybody. I just want you to get as much information as you can, so hopefully you have the same experience and changes in your life that I currently have. And last but not least, I just want to say, we have to pay homage to those who've come before us. And I have numerous mentors who've helped me see the light relative to certain technologies. And this is the point where I can't name them all, but I just like to say thank you, because these are not my topics that I invented. These are not my ideas. We just stand on the shoulders of giants who've come before us. So let's talk about today's topics real quickly. I want to talk about what I was using. I want to talk about how I see things now. I think it's important to talk about where has CBCT made a difference in my practice. And last but not least, we're going to go over some cases. And I'm going to talk to you a little bit about how I chose the cases we're going to go through when we get there. So let's start with where was I, right? It's a great question to ask. You know, how did I end up here? Well, you have to go back to where I started. Now, we all have our own stories, and many of our stories are winding roads, and mine is no different. I was a cosmetic and restorative dentist for 20 full years, a fellow of the Academy of General Dentistry, still am, even though I am a board certified orthodontist. For 20 years, I was a general dentist practicing and starting in New York and then ultimately Seattle. Sold my practice and went back to school as an orthodontic resident. I was 20 when I started dental school. I was 44 when I started orthodontics. So I was the youngest dentist that year in the US, and I was the oldest resident when I went back. So my journey is a little bit different. And I didn't know the first thing about CBCT when I was a restorative dentist, other than the fact that they came on these weird little discs that annoyed the bejesus out of me. I couldn't read them. I couldn't see them. My surgeon would send them to me, and I had no idea what to do with them. And then I went back to residency, and I started learning a little bit more about it. And my master's thesis, when I graduated from my ortho residency, it hurts me out to say this out loud because it was so painful, but cephalometric regional superimpositions, digital versus analog, accuracy and precision, I worked on the maxilla. And all I did all day long for months on end was sit in a dark room with lateral ceph tracings and just measure and measure and measure and measure. And the whole goal of this study was to check analog, as it says there, versus digital, which was CBCT, or in our case, it was digital cephs. And so my life was cephs. And so when I came out of school, I was ready to attack the world with cephalometric radiographs through and through, because this was exactly what I did on a regular basis. And as my master's mentor said to me, you know, when you spend 2.5 years on one little topic, you become a world expert on it. Well, I left dental school or ortho residency as an expert in lateral cephalometrics. So if I'm going to make the change to CBCT, there had better be a good reason for it. So this was my life, right? This is the life of many of us out there. It's nothing more than a lateral cephalometric X-ray, and I'm sorry, a panoramic X-ray. And we're just kind of looking at a case and seeing what we've got. And, you know, as we move through these sorts of things, there's your lateral ceph. We can take our measurements. This one was brought to you through a CBCT, which I brought down to a pan and a ceph. And this was what I did for the first, I don't know, 3.5 to 4 years as an orthodontist. And the practice I bought happened to have an old unit, and this is what I worked with. And cases turned out fine. And I always heard people saying to me, once they got a CBCT, they could never go back. But it's not a cheap investment. There is a bit of a learning curve. And I just felt like, you know, I'll be absolutely fine working with a CBCT without a CBCT for the rest of my career. And so that very case, if you look at that exact case, or if you look at where we're looking on this particular one, the ability for me now, and again, it's a different case, but my point is, for my ability to look at a case and zoom in and see it from every dimension, to be able to look at it from different perspectives, to allow me to look at the nasal floor, to allow me to look at the teeth, to allow me to look at the bone and widths and from all three planes. You know, you can look at axial, sagittal, coronal, however you want to look at things, you can see it. And so when I was done looking at this, you know, look at the joint, for instance, as you're seeing right there, to be able to look up into the nasal floor, which is something that is a very large part of my airway-driven practice. And I'm going to get a little bit into airway today. I'm not going to touch on it a lot because it's a very, very broad topic that you just can't learn standing on one foot. But again, this is the world I now live in, as opposed to you know, the regular lateral ceph world that many of us live in now. So I want to show you a case, Morgan. He's a little over 8 years old. And He shows up at the office, nothing really crazy. You question mom and dad, and like many moms and dads, there's a lot of denial of sleep disordered issues. But yeah, he snores a little bit, and yeah, he's ADHD, and he doesn't do so great in school. But he's a normal kid, right? That's what the parents will say. So let's just take a look at his case, and I'm not going to bombard you with photos today. We're gonna live in typically the radiographic world today. But I wanted to show you this case for a couple of quick reasons. So take a look at his case. Nothing really remarkable for an orthodontist, nothing that we look at here and say, wow, what a crazy case. It's pretty typical. Class 2 with a end on one side, class 1 on the other, so it's a subdivision case. You can see how the anterior teeth are proclined and protruded. And let's take a look at the lateral ceph, which is really where we can make our determinations about skeletal relationships. You can look at the airway a bit if you want to look at the airway. You can try to see the condyles the best you can. You can see your overjet. But as we look at him from a panoramic view, again, nothing really remarkable here that jumps out to you and says, oh my gosh, look at this crazy case. I can't believe this impaction. You're not going to see that here. You're going to see a pretty typical kid, which is what mostly walked through the door of my practice. And again, if you want to play with the bells and whistles on the CBCT, on my iCat Flex, which is what I use, we can play around with all of them, looking at airway, sinuses, the whole 9 yards, and see everything. But again, we can see things very, very differently when we rotate and play with this. And we'll get into this more in just a little bit. We only have 45 minutes to an hour today for the entire session. And so I don't have the opportunity to really do a deep dive into this. But let's go where we are right now. If we're going to look at him from sort of an axial perspective, and we want to look up, if you will, at his teeth, at his joints, at his nasal floor, look at that nasal area now. Look at that septum and look at his turbinates. Right? We think of airway, and everybody always talks about airway, airway, airway. Oh, expand, expand. You have to give this appliance. I am an interdisciplinary airway guy. I have 5 people on my airway team, and we meet typically to just go through cases. But how does this kid breathe? Look at the nasal septum. Look at the turbinates. Right? There's a little stuff inside his maxillary sinus, on his left maxillary sinus. You may think it's funny, but it's not. It's a great joke. It kills every time. But at the end of the day, look at his nasal septum. Now, you might say, well, what do I care about this for? But if we're really going to walk the walk and not just talk the talk about caring about our patients, if I can spot this and see this in a child, and it's more than just orthodontics, and maybe get my ENT involved, my airway-centric ENT, that's the name of the game. Because there's too many people out there talking about just treat airway. You can do this yourself, and that's an absolute lie. You cannot treat this yourself. You should not treat it yourself. Can you fool yourself into thinking you can treat it yourself? Absolutely. But you need to be part of a team. And I stress that to everybody when I teach airway-centric orthodontics and the interdisciplinary model. And look what I can see on this child right now. And so this is going to get a referral to my ENT as well as me doing some treatment. And best of all, my ENT loves getting this image. Now, I'd sent it to him for months and months and said, Dale, you're really reading these things. I thought, I was just sort of sending it, making myself feel better. But he said to me, he loves it because they would never spend the radiation to take a full medical CT, and the low dose radiation of what we're doing here on these kids in a typical exam saves him the trouble in many cases of a full CT, as well as this is a great augment to his endoscopy or when he looks up the nose real quickly to see things. So how can I do airway orthodontics fully and completely without a CBCT? I can't. So this is just one small example, but let's go look at his mouth a little differently. Again, nothing jumps out to you here. He doesn't look crazy. This is a classic 8-year-old boy that I see in my practice. But look at the lower molars. Look at the way they're tipped in a little bit towards the lingual side. Look how the tongue almost rolls over the teeth a little bit. These are warning signs that anybody learning about airway starts to look for. And so there's a great paper I want to bring to your attention that was in the AJDO in 2012. There's 2 parts to it. This just talked about how they look at CBCTs in a different way. And one of the things they identified that's really important to look at is look at the upper arch versus the lower arch. And it's hard to do it justice without having it right next to you. But look at the palate on the letter A, right? Look at the width of that palate and look at the lower arch width. and look at where the teeth are. And that's considered a normal, typical bite. However, what we often see in orthodontics is what's in B. Now, what do you see in B? You see no crossbite, correct? The upper teeth are outside of the lower teeth. And many people would look at this and say, hey, this kid is totally fine. We don't need to do anything. However, what would happen on those lower teeth if they were uprighted appropriately? You would be in crossbite. And if you look at the palatal width as another example, it tends to tell you that the maxilla is narrow, and it's narrower, the width, than the mandible. So looking at the inclination of those lower teeth, you know, what makes up, you know, the curve of Wilson, Monson sphere, however you want to refer to it, when those lower teeth are tipped in considerably and we upright them, we're going to put these people into crossbite. And that's a skeletal issue, not a dental issue. And so they did a part 2 where they in 2015, a few years later, same authors, and they show these 3 different kinds of cases. And again, you should be able to recognize them at this point, the normal, you know, the superior convergent and the inferior convergent as they referred to it. And again, look at the width of the palate versus the width of the mandible. Now, if you don't have a CBCT, you could certainly scan somebody, print out some 3D models and measure them. You could take alginates and measure that, but you can't see the bone. You can see the cusps, which doesn't really do it justice. So for me, without having a CBCT, I can't do any of this. And it's really a big part of my practice. So again, this young man that you just looked at, right? To keep it easy, you know, there you can see what was in his sinuses, right? But look at the inclination of the lower teeth. Look at where the bone is on the ridge of the lower teeth relative to the upper ridge. So I could see this child in my office and say, oh, this is a kid, I'm just going to put some braces on him. And that's that. But at the end of the day, you know, if I said, well, I'm going to do an expander, a lot of restorative dentists would look at me and say, why are you expanding this child? He doesn't have a crossbite, but he does. He has what you'll refer to almost as a virtual crossbite, a silent crossbite. The alveoli actually are, you know, in crossbite, for lack of a better description. And the best part is when I expand him and I widen the palate, what's on the second floor above the palate? The nasal floor. So when I widen his palate, I widen his nasal floor. And in doing so, I open up the room. And if you know your laws of physics and the flow of any sort of airway or liquid, you know how turbulence plays a role relative to room created, if you will. And it's not equal. For every millimeter, you get 4 times or to the 4th power amount. So again, if I open up his palate, as I've seen hundreds of times, his mom is going to say how he might sleep better, he might do better, he might do better in school, ADHD might diminish or go away. And I don't promise that. But what I will promise is that I will put the teeth into the proper position. And that's the name of the game. If I'm already doing that and I open up the palate and I open up the nasal floor and this child can breathe better, sometimes you will see those turbinates shrink. Now, I'm not going to be able to magically make his septum straighten, but there are many cases where we expand, and in doing so, you will see a septum, instead of being curved completely, straighten out a bit. So again, I can't treat without this view based on the literature that I've seen that I just demonstrated with you. So let me show you a couple of places where CBCT has really helped me. Diagnosis. One of my mentors, the late, great Dr. Morton Amsterdam out of University of Pennsylvania, for any restorative dentist, he was the godfather of the modern periodontal prosthetic approach. And he was famous for saying that for every patient, there are multiple treatment modalities, but only one correct diagnosis. And remember that, whether you're ortho, restorative, endo, pros, doesn't matter. You have to diagnose the case properly, because if you don't, you're going to head off in the wrong direction real quickly. And all too often when we treatment plan cases together as a group, everybody jumps to the treatment plan and not the diagnosis. And CBCT has helped me tremendously in getting the right information so that I can properly diagnose a case. The second place that's helped me tremendously is form and function. You know, in order to satisfy a good outcome, you need to have both form and function. As I demonstrated from that first case, I could put a wire in and straighten those teeth out. But if those lower teeth are still tipped, you know, lingually, I haven't treated the function. I've treated the form. And so it's very, very important for me to put those teeth where they belong, create proper form and function, and that applies from the chin up to the nasal airways. So again, CBCT has helped me there tremendously. And of course, patient engagement, because all too often I try to explain to parents exactly what's going on with a case, and it can be very difficult. Photos traditionally used to do that for me. Now it's a CBCT because, as we know, every picture tells a story, right? It doesn't take a genius to figure out the story in this genius's weekend. But then again, I think we've all been here at least once in our lives. So again, it's helped me with those three things. So right now you're looking for cool stuff, right? This is a lecture on CBCT. I want tons of cool stuff. Well, you're not going to get cool stuff because that's not what I want to do. I don't want to wow you with really cool stuff, cases that have a tooth coming out the eyeball and how I pulled it into place, because that's not real life for every single case. And many people will use that excuse to say, oh, I don't see a lot of those, so I don't need a CBCT. And I'm going to change the screen so that those of you out there who are about to throw up don't. But I want to show you that this is a patient who had a dome procedure done. Now, for those of you who don't know what a dome procedure is, they cut right over here and you cut down the palate, and we put a MARPI, a mini implant assisted rapid palatal expander, in the arch. And I do these all the time. I was lucky enough to train with Dr. Juan Moon from UCLA, and we do these. And the nice thing with the CBCT is I took this after the fact, because how can I really objectively see the kind of changes I've had skeletally when we've done it? So if you look at the cut over here, and you look at the cut over here, and you'll see the appliance, which looks like a tooth-borne RPE, but is actually a bone-borne. Just, you see how it's placed there. Look in the middle of the palate. That's how much width we created through a distraction osteogenesis of the maxilla. That's how much room we created instantly without having to go through a full SARPI procedure where there are cuts back by the pterygoid plates. And that's what keeps people in the hospital overnight, because of the maxillary artery branches that run through there. We can avoid that altogether, be safe, be effective. And I hope to have this done to me at some point, because if you have a narrow maxilla with a high palate, you have trouble breathing, this is a very, very straightforward, simple, easy fix to be able to do this. But if I want to look and see the space that I've created, I need to objectively look at it. And so here's a great way to do it with a CBCT, right? I can get rid of layers. I can remove things so I can see it better, right? I can build it in any direction I want. The voxel size on this image is just standard, 0.3. But I can look and see anything and everything, and I can show a patient, you didn't go through this for nothing. Look what we've created. And I have many, many, many cases that would have otherwise been two-jaw cases that we are now treating with dome procedures that is really making a difference for people. So what I chose to do for you today, instead of showing you the cool stuff, is I figured the safest, most intellectually honest way to treat this would be, the question is, which of my patients require a CBCT? I went to my server and took consecutive cases that were on my server. Just went to my server, looked to see what cases were on there that we had acquired or were looking at, and just took 7 or 8 straight cases right off of there. So when I went into them, I had no idea what we were getting involved in, had no idea, was there an impacted tooth or was there absolutely nothing? And so I'm being honest here when I show you cases. Some of them are going to be, wow, that's pretty cool. And some of them might be, yeah, that really would help me in a non-cool way. And so let's start talking about some cases here. So this is Madeline. She's 10 years, 7 months, and there's her lateral ceph. Nothing remarkable to jump out at you right now. Airway looks reasonable, right? If we're looking at it from a lateral ceph, not excessive overbite or overjet, and the proclination of the lower teeth looks pretty good. If we look at her Panorex, more starts to creep up right now, right? She's missing an upper left lateral incisor. Her upper right lateral incisor is a peg, right? We always look for these sort of oddities when we're missing a tooth. Her upper left cuspid is erupting into the central incisor. She's got some crowding of the lower arch, crowding of the upper arch. So, again, I wouldn't look at this case and say, oh my gosh, what a difficult case. But certainly there are going to be decisions that have to be made in terms of diagnosis, right? Remember, diagnosis, that's the name of the game here. The upper second bicuspid seem to be coming in a reasonable direction, and all the lower teeth seem to be coming in a pretty good spot. So now take this case and look at her, look at those two particular areas, right? Where is that cuspid and coming in on the left against the central? And how long is my root really on my lateral incisor? And where is that cuspid erupting? Well, let's take a look at it and see what we've really got. So all of a sudden, I noticed that, if you take a look at that cuspid on the right side, where is it relative to the arch? I can see that it's a little bit buccal. I can see that my upper right second bicuspid is coming in palatally a little bit. If we look at the upper left cuspid, you can see where that's coming in. And again, you can see how your upper left second bicuspid is erupting to the palate slightly. And you can see the buccal root of that upper first primary molar, second primary molar is not being resorbed. If we take a look at the arches, looking at the nasal cavity at the same time, septum looks good, turbinates look pretty good. If we're looking at it from a sagittal perspective, airway looks pretty open, right? And so we're starting to get a better idea of what we can really see in this case when we look at it. We're seeing lots of things. Let's look at it, from the bottom up, looking at this case. And as we get there, right, the sinuses look wide open. The septum is pretty straight. But again, when I talk about looking at this case from every single direction, I really want to see where those teeth are. And my ability to scroll through the entire arch and really get a good idea, okay, where is that cuspid relative to the lateral? Where is that cuspid relative to the central? And as you can see me zooming in and out there, right, I can pop back over here and say, is it really touching the central or is it off just a little bit? Is it really touching the lateral or is it off just a little bit? So now we're going to go back to what I would have used if I didn't have a CBCT. And again, to me, it's a totally different ballgame. There's so much more information. Now, you could make the argument, I can take a PA ceph, I can take an off-angle occlusal. You can do those things. But to me, that's kind of like a workaround. It's like if I have a car and it's raining, why would I take a motorcycle to get to the store? Could I do special jerry-rigging stuff to make it work? I could. But at the end of the day, I can tell you this patient will get a better diagnosis and arguably a better treatment plan and certainly better tracking as I take other radiographs and a better explanation to mom and dad than I could with any lateral ceph or panoramic film. So let's go on to Whitney. Whitney's 34 and a half, give or take. She has that excessively proclined and protruded upper central incisor. So lowers are also a bit proclined, a bit protruded. She is a tongue thruster. She comes in knowing that. She's been a speech pathologist. We know there's an issue there. And again, here's her lateral ceph. Airway looks pretty good. Can't really tell the joints, but if you looked in carefully, the joint space might look pretty good to you. Like I talked about, there's excessive overjet. And there's her panoramic x-ray. She goes to a dentist every now and then, like many of our patients do. And she has some pain in her lower left. Now, again, remember, I am showing you consecutive cases. This is not me going into my archives and trying to dig out the coolest cases I could find. These are typical cases that walk in my door every single day. So again, look at her lower left second molar, okay? I want you to pay attention to that because look what's going on around the apex there, right? Is that a radicular cyst? Is it something else going on? Also notice here when you're looking, right? I want you to look at the lower third molar, right? Especially lower right third molar. It's really nice for me to be able to share this with my surgeon or restorative dentist. And as we look at that lower second molar, look at what's going on down there. You can really see it in a very nice way. And if you want to remove some layers, remove them, right? And rotate it so you can really see what's going on down there. You can zoom in if you want to and look at it from a different perspective. But I know for sure my restorative dentist and my endodontist would love to see this film. Look at that on the right side of your screen, right? That's the lower left. Look at that tooth down there. Look at the radiolucency around the root, and you can get a very, very good idea when you look down on the tooth, right, or up at the tooth. You can really see what's going on there on that lower left side, the obliteration of the bone that's over there. So at the end of the day, is this going to help my doctor? It's not going to necessarily help me with ortho a ton, but again, I'm going to come back to the question, who are we trying to help, ourselves or the patient? Are we trying to give them better care? There are going to be cases where I'm going to help them get better care and it won't involve me on any level. But I can avoid bigger problems if there's a cyst, if there's a growth, or something they wouldn't have seen otherwise. Now take a look at that tooth. Look at the size of that area, it's humongous. And again, you're still going to take a PA if you're treating this up close, but it's a really nice way to share this with my restorative dentist or my endodontist so they can make a better diagnosis. Right? Now, this is what I ordinarily would send them. Now, you might say, well, you could tell it was there. We can really see its location relative to the proximity of the other roots because we can look at this from an axial perspective. So let's talk about Ridvika. Very, very sweet girl, 14 years old. Again, airway looks a little bit narrow from this perspective. Lower teeth are proclined, protruded, typical compensation of a class 2 case, right? Here's the panoramic x-ray, right? Looks like we're missing a tooth, a central incisor. Very, very sweet girl, wheelchair bound. And one time getting out of her wheelchair, she tripped and fell, right, getting out of it. And she smashed her front tooth and knocked out, avulsed her upper right central incisor. Well, I want to take a look at her jaw joint for sure before I treat this young lady, because if she's had trauma, I'm going to try to take a peek at that. And so the nice thing about a CBCT is, yes, we're going to see all the teeth, we're going to see the nasal floor, but look how it allows me to really, and again, if I could go full screen for you, I would right now, but we're in presenter mode. Take a look at how I can see the condyles from every different direction. What you see in a typical 2D image doesn't really let you see everything. If you look at the lower left picture right now of the 4 quadrants, I'm sorry, I pulled it away from you in my video. I didn't want to do this live on my CBCTs because oftentimes things can glitch and technology can cause a problem. But take a look at that lower left image and notice how we can see the condyle. Notice how we can see the shape and the form of both condyles very nicely from this direction. And again, I want to see that joint space. I want to see the cortication around the outside of it. I want to make sure there's not arthritic change. And of course, I'm going to look at everything else that goes along with this particular case to make sure it's looking good. And so again, if I'm working with just a CBCT, a lateral ceph or a Panorex, I'm not going to see the things I really, really need to see to treat this case. And again, there's an avulsed upper central incisor, and that's certainly going to play a role. But my ability to look at this in a broader way really helps me. And again, these are consecutive cases. This is not a consecutive case. This is just a reposition mid-course evaluation. I wanted to take a break from cases for just a minute or two, just so I can show you the difference it's made in my office when I want to stop and reposition or do a mid-course evaluation or figure out where things are going. I'll show you one of the cases that is one of the consecutive cases in a little bit where it's making all the difference for me. But again, this is my typical low field, smaller field reposition CBCT that I would take. And it doesn't come through as well here as it does on my screen in the office on a higher resolution screen. But here's a young lady, impacted upper right cuspid, palatal expander in place. And again, this is what your Panorex might look like if you took a smaller field image. This is what it's going to look like when you do it in a CBCT. Now, again, I can stop at any point along the way here when I take a CBCT and really evaluate not only the position of the tooth, but more importantly, what's going to broadly occur to most of my repositions for my normal, not abnormal patients here in terms of root position, is I'm going to really be able to see in 3 dimensions where are my roots so that I can get a better idea of root position and reposition than I would if I was just taking a panoramic x-ray. Again, I love the idea that I can look at it from any angle, up or down, forward or back, and really start to evaluate where are we? What's going on here in terms of all 3 planes of space when it comes to looking at where my roots are, right? So I can really get a good idea of where do I need to put my bracket to fix what I need. And the good thing is I can have this up in front of me. And the cool part is you can cut half of the arch off as you're doing this to get better contrast so the background is black, and then do it on the other side. So you can really see the roots in an easier, simpler way and see where things really are. So again, for repositions, it's made all the difference for me and my ability to finish cases a little bit quicker, with a little bit better of an outcome. Again, this is what I would ordinarily be working on with a CBCT. And as we know from more than 1 or 2 studies, if upper anterior teeth are proclined, you're going to start seeing some interesting artifacts on a panoramic x-ray. Oftentimes, if they're really proclined, you're going to see what looks to be like root shortening when in fact it's not there. So again, this gives me peace of mind when I go to my CBCT and look at things. So let's look at Alice. Going back to some cases here, we've got about another 15, 20 minutes. Alice is 11 and a half years old, give or take. Again, look at the airway, looks great. Nothing remarkable about her case, nothing that jumps out to you that you're going to look at and go, how am I going to treat this case? What am I going to do with it? It's a pretty typical case. Again, my goal here is to show you normal stuff, the things that are going to come in your office, because I am one of those people who's going to tell you I could never imagine going back to treating without a CBCT. It just shows me too much. And that little bit extra of what I need to see is often found in the CBCT on a normal case. So you can look at this case. Does anything jump out to you as being abnormal or strange? Not really. This is a kind of a typical bread and butter case in most of our practices, right? But now let's look at it from a different angle. Let's look at this from a CBCT. And again, these are all standard res, no high res images here. But look at what I can see. Where is that tooth? Oops, sorry. I'm going to go back for you for a second. Bear with me for a moment. Sorry. Let's go back to this and let's look and see, where is that cuspid really relative to the arch space that I have? How nice is that for me to be able to look at that? Now we know we're short on space, but how much are we short on space? Because there are formulas we can figure out in terms of proclination of teeth, in terms of expansion of teeth, in terms of distalization. Where am I going to get that exact space? If I can measure that, which I can using my CBCT, I can measure the space I've got and the width of that cuspid. Now for my equation, I know exactly how much room I have. But I don't get this with a pan. I don't get this with a ceph. And this is my bread and butter case. This is what walks through my office on a regular basis every day into my practice. And again, just straighten it back out for you. And again, let's look at the other side. Look at what I've got. Now, I show this to mom or dad, and I'm not going to talk about the treatment plan for this case. We're talking about diagnosis. But if I were to talk about treatment planning, I could talk about distalizing the posterior segments, right? If I felt that was appropriate. And mom and dad would absolutely, or the patient would absolutely understand why distalizing that segment could create the room I need. I could talk about an extraction, right? Which is a very viable option here. Take out an upper first bicuspid and let the cuspid come into place and bring everything forward. I'm not saying I would do that, but it is an option. And again, you can explain it really nicely with this view. And that was the third point I made earlier about the 3 places it's really helped me figure out to use it. So again, look at that distance. You can see it crystal clear. I can look at my root lengths. Look at that lower second molar. It looks to be impacted. We can take other pictures and see it, but again, we can look at it from look at the widths of the maxilla versus the mandible. You can go back and look at the joints if you want to, which you're about to see, right? You can see the TM joints, which is beautiful. You can come forward and back as you see the case. Look at the nasal passages, look at the turbinates, look at the septum, look at the sinuses, and don't be worried by people out there who convince you or say, if you get this, you're going to have major problems legally because you're responsible for everything, and you're not. I've heard lawyers talk about this. We are not MDs. We are not experts of the entire head and neck. And because it's just on there, now this is not my opinion, this is theirs. Just because it's on there doesn't mean that it's our requirement to see it. But I'm telling you now, the same way you learn to read a pan and ceph, you're going to learn how to read these cases. Now look at this lateral ceph. This is her case. This is Alice's lateral ceph. Think of how much easier it is for me to relate this case to mom and dad. And I'm not a big fan of people saying, oh, you'll make your money back, because then we've monetized, our business. But at the end of the day, it needs to make money for us or it's not worth having. How am I going to explain to mom and dad about my whole plan using this image versus a CBCT looking from the angle I showed you earlier, right? It's very, very difficult. And look at the space we have. Very tough to see on a Panorex. So again, this is a spot where it's really helped me. I want to show you Alyssa, who showed up at my office with some teeth missing and some appliances in her mouth. Look at the airway again, which I always try to do when I was on a lateral ceph. Take a look at where the teeth are. Look at the upper second bicuspids or lack thereof. Look at the lower second bicuspids or the lack of 2 of them. There's one more coming in. Do I keep it? Do I get rid of it? Is it going to form normally? What's going to happen? So again, if I go into my CBCT, again, let's pause this for just a second because it's only about 15 seconds long. And I'm going to go back for a second because I don't want you to look at that big thing there, which now you're focused on, of course, right? You can't not look at it. But if I get rid of it and take you back to here, look at all the things we can see here. We got the maxillary sinuses, right? We've got our things that are in our world: maxillary sinus, nasal floor, turbinates, maxillary teeth, mandibular teeth, both arches, and we can go to TM joint if we wanted to. my entire exam from A to Z, sequentially, the same way I do a pan-ceph, takes me about, give or take, a minute and a half total. And I'm narrating as I go through it with the parent. So I want to be crystal clear to you that, A, don't be nervous about the legal ramifications of this. I would implore you to go search the history of orthodontics and CBCT and find out how many lawsuits have been leveraged and won, or levered and won against orthodontists, and send me that number if you can find it, because I can't find any. Number two, I'm not going to let you think like it's going to take over your life in terms of diagnosis and treatment planning in terms of time. This will take you a minute and a half at the most from very beginning to very end, and you will feel really good about the information you've got. Now, as I showed you earlier, right, there's this little globule there. Well, what is it? I don't know. Your differential diagnosis could pop up a few things, but the good news is I can share this really easily, and I love the way the ICAT stuff shares through Anatomage and shares to my specialists. I will typically, and I will tell you this, I will say to the patient right in front of me, hey, there looks to be something in there. I think it might be a mucus retention cyst, which we're not going to do anything about. But I'd love to take a picture of this with my phone and text this to my ENT. It's not HIPAA compliant, but I want to get your permission to do that. Now, you might say, well, I've broken the law, or it's not documented any other way, but everything in my office is on video and audio. And they say, sure, no problem. And they're scared about somebody stealing this. So I send this to the ENT, and by the time the exam's over, typically my ENT, if they're not in surgery, will say, don't worry about it. And I'm actually saving them a visit. So again, you're going to find some curious stuff from time to time, but you look in the sinuses, that's not normal. You spot that a mile away, and that's the kind of stuff you're going to see when you do a systematic view or exam of your CBCTs. So again, remember, this is consecutive cases. This is not me cherry picking. And this is what's coming through your office on any given day. Okay, so don't think for a second that this is stuff that you're not going to see. This is Santiago, the next case. That's a pretty big mandible, right? And we're not going to get into the discussion right now on this 13-year-old about whether we're going to do surgery or not do surgery. This is a discussion about cases and which of my patients need CBCT. And I want you to look at Santiago's airway. I want you to look at his teeth. And I want you to notice there's a little bit going on here, right? We've got a tooth that looks to be coming in a weird position. It looks a little bit like a driver from golf or a club foot. But take a look at it, and you see what you've got here. And what are we going to do? He's got a retained upper primary cuspid, and that's a lateral incisor that's actually posterior to the cuspid. So how are we going to treat this? Well, again, let's go back, as Blue's Clues used to say, to our handy dandy CBCT. And let's just look around and see what we've got here, right? So on his right side, nothing really too remarkable in comparison, right? We have a cuspid that looks to be resorbing the primary cuspid root. Everything looks to be going pretty well. We come over to the left side cuspid, and it's in a funky place. The good news is, it is transposed, but the root seems to be in a good position, right? So I'll let you debate whether this is a full or a partial transposition. I would say it's a partial transposition, but you could also make the argument that it's a full transposition. And so take a look around and see what you've got here relative to the lateral incisor, relative to the cuspid, relative to the central. Don't worry about the primary tooth right now, but let's look at this from a different direction. And let's really try to see where this is. And again, as we go through this, this gives me functionality that I cannot get with a regular pan-ceph. Again, look at where that cuspid is relative to the central. Again, I can look at this from any angle I want before I have to make a decision. And I want you to remember diagnosis. This allows me the opportunity to diagnose. I don't have to jump in and tell a parent, here's what I think we have to do, but I need to send you out. Right? And this is really a beautiful image for me to look at, right? When you're rolling through this, take a look at where the lateral incisor is relative to the cuspid. Where is that? It's right on top of it, right? So we have considerable risk of resorption, which I want to tell a parent about as we move this tooth, unless we're looking at extracting something. And so we get them 4 months into treatment. And then, at this point, for a whole series of reasons, we did not take out the primary cuspid to begin. I'll get into that discussion another time. But I wanted to leave that left side primary cuspid to act as sort of an anchor to keep the lateral from going more distal. I didn't want it to go distal. So again, this is the CBCT I've got. It's not bad, right? It shows me kind of where the cuspid is relative to the lateral, but is that the right side lateral, the left side lateral, right? Our tooth is certainly coming into a better position than it was to begin with, but I need to see a little bit better. So let's see what we've got here. Now I've got separation, right? Oops, sorry, I'm gonna go back here for you. Sorry, I keep going back. Right, so now I've got separation, right? I truly have room between, without putting a bracket on that cuspid, I truly have room now between my lateral incisor, which I brought the root palatally slightly. I've created room around that to allow that cuspid some room to go distal, right? We can see the length of the root. We can visualize it. We can see what we really have. Now it's time to take out that primary cuspid. Now it's time for me to let that lateral incisor stay mesial while we put a chain on the cuspid and bring it distal a little bit more. And again, I can get rid of the opposite side so I can really see what's going on there. And if we go back to where we started as a superimposition, not a true superimposition, but for you to be able to see them both, you can see we created room, which for me is the name of the game. So again, if I'm going to look at this with a lateral incisor or a central, a ceph or a pan, there's no way I can get this kind of peace of mind. And again, we're going to deal, you can see a space on the lower, we're going to deal with the overjet, overbite issues, which is what we tend to look at as orthodontists predominantly, is overbite, overjet. But look at that picture right there. Look at what I've got from that cuspid to lateral incisor root. I have room now. Not a ton, but I certainly have room that I didn't have there before. And that's where CBCT is really helping me with him. So again, we're almost getting there. Just got a couple of more cases. I'm just going to show you Roman, 14 years old, almost 15. Again, edge to edge, nothing really too remarkable about the case, nothing too crazy. But as I put Roman in the chair and I'm lying him back, I'm listening to this kid and it sounds like a guinea pig is in the room, right? You ever listen to a guinea pig snort? He's really nasally obstructed, but mom is denying all questions on the, I used the University of Michigan Pediatric Neurology Questionnaire for sleep, the first page. Nothing comes up, but I want you to start looking, okay? If I've trained you about anything, what are we looking at? We're not looking just at the teeth at this point, right? There's other stuff going on here, right? Look at the width of the lower versus the width of the upper, right? Look where the teeth are, right? I want you to look at the nasal floor, right? Look at the turbinates and look at his ability to breathe. Now, mom has never had a problem. He's how old did I say? I think he's 14 or 15 years old, almost. The physicians never said a word because they don't have this view. Pediatrician never said anything. Nobody's ever said a word to this child or mom about how we can help this child potentially breathe better. Now, you're not hearing me talk about jumping to treatment plan with what we need to do. I'm just saying, look at the floor of that nose. Where is he breathing through the left side of his nose? We know that the majority of airway resistance comes from the inferior turbinate, right? So again, look at that. Look at what you're seeing right there. I can guarantee you that if this child gets help, he's going to breathe so much better. Yeah, but where's the victory for me? Well, this is one where you did right for the patient, and it doesn't really matter if you made a penny more or not. You're going to help them. It'll help your treatment plan. But again, sorry, I'm going to get back to that. But again, do I want to diagnose with this and this? Kid's almost 15 years old, has slipped through the medical industry, and now I get to see turbinates and septum and other things that is going to make a difference. Again, Julian was a virtual consult in my office. Again, I told you, these are recent images all in a row. Julian was a virtual consult in my office that I ultimately brought in before we were shut down. I did a virtual consult and then brought him in to do a CBCT to do a real final exam. And this is where you need to be careful with virtual consults, because he showed me his teeth and I saw everything and I said, looks pretty good. Here's what I think we're going to do. And I always say think, but I need to get you in for a CBCT to go look at things. And you can already see it from a mile away, right? What are my concerns? Impacted third molar. But what's that going down there? It's your classic, right? Everybody has 3 bicuspids, right? Obviously not. But I couldn't see this on a virtual exam. He came in, I took the x-ray, and lo and behold, it's there. So now, if I'm the kind of orthodontist who's promised a lot, I have to now backpedal, right? And he's really proclined and he's really protruded. And I want to go back just for a second. He's a 4-by extraction case to me, all right? And the face certainly is not horrible, but it could benefit from 4 bicuspids. So my question to you is what bicuspid you're going to take out going to make a difference depending upon what you see here, right? Am I going to take out lower first bicuspids if the surgeon needs to go in and take out that tooth? And do I want to make a decision on whether they need to take out that tooth based on this x-ray? Or do I want them to really be able to see it in a CBCT kind of level, right? Again, if they've got to take that tooth out, I can't imagine them wanting to take out the 4 or the first bicuspid and dig around for that tooth around the apex of the second bicuspid. So I'm not saying I would take out second bicuspid if that tooth were taken out, but maybe I would. Maybe the surgeon would prefer it. I don't know. It's going to play a role. I need to see that root from every angle. I need to see where it is, right? It looks like it's really lingual. So maybe we do take out our first bicuspids and they just pop that baby out to lingual and everything's fine. But what if it was stuck directly between the roots of the 6 and the 5, right? Then what? So for me, that's a huge difference in terms of my ability to see what's going on. And so the one thing I do want you to see here, sorry, I'm going to bring it all the way forward here. I want you to look here and I want you to see this, right? That area, as we look from a different angle, you'll see it come back, is the adenoids, right? So look how big his turbinates are, right? Everything was big, but back here, when we went into the throat, the pharynx, you'll see there are your adenoids, right? Look at the soft palate area. Can this child, this young man, breathe when he lies on his back? This is a case where I'm going to treat orthodontically, but this radiograph is going to my surgeon, my ENT, so that prior to him ever being treated by me, or maybe during, my ENT can help get a good idea of what's going to happen. And if we do a CBCT evaluation of the airway, I'll get 151 square millimeters. Now, again, I don't put a lot of weight on this. It's a one-time shot, and there's some really, really good studies out there that say that this is just a one-time image, but it's a great place to start in terms of evaluating the airway. If this was 50 or 60, I'd be much more scared. But look over there. Those are the adenoids. And how do you learn this? A, by doing it. B, by sitting down with your ENT and saying, hey, I'm going to run through an entire CBCT with you. Can you teach me? Show me. One of the most important things for us as healthcare providers is to admit what we don't know and to be vulnerable and say, I don't know how to read a CBCT. Can you help me? From a nasal and airway perspective. And again, that's what's being lost in our airway discussions. Everybody's an expert, but you're not an expert in everything. So that's why I have an ENT on my team, and I brought him into this. And again, am I going to make my decision on this? No way. Look at how much I just missed from an airway and a diagnosis perspective. So again, I'm going to go back to the original question as we're wrapping this up. Which of my patients needs a 3D image? And you know the answer already. The answer is all of them. Because every patient I showed you in consecutive order of them being on my server, which means showing up and us viewing them, needed a CBCT. So, or you can say maybe they didn't, that you're going to farm it out. You're going to send it to somebody else. Let somebody else be worried about that. But truthfully, doing it in-house makes it so much easier for you to evaluate. And you're going to not send out every case for a CBCT. Having this in-house has helped me tremendously. It's helped the practice grow a bit, but it is really a marketing tool for me to be able to tell people, look at what I'm looking at. And it's just another way of showing my patients how much I care about them, because at the end of the day, this is what I miss right now, being stuck at home. This is what makes me get up every morning and go to work, because I absolutely love what I do. I could not imagine doing anything differently. For you orthodontists out there, I hope you're signed up for our Orthopreneur Summit, October 15th and 17th. We hope it's going to happen. I'm telling everybody, if you sign up and it does not happen, you will get every penny back if it doesn't happen because of COVID. We've got some amazing people speaking there. It's going to be just absolutely amazing. It's at the Fairmont in Austin, October 15th to 17th. Again, you can always find me on the web. I've got my podcast, which I try to drop every couple of weeks. We've had about 80,000 listens of that. You can find me on Instagram under Glenn_Krieger_ortho. You can find me on Facebook just as Glenn Krieger. And my personal email is doc@kriegersmiles.com. Again, if you ever want to read my blog or anything else, just go to orthopreneurs.com. That's where most of my stuff is hosted. But you can always reach out to me. I'm always here for you in any way you need me to, because none of us is in this alone. So with that, I want to say thank you. And Adam, if you were asking questions and I didn't see them, I apologize. If you want to ask them now, please feel free to share them with me.
Absolutely. Thank you very much. We do have some questions.
Sure.
Are your CT scans being viewed with Anatomage software?
Yeah, I use Anatomage to view everything. It works great. The sharing feature is spectacular. And it's just so simple. No more giving discs to people or giving flash drives. Yes, I do read it in Anatomage.
When you view the buccal and labial bone level on CT, has that changed your mind about treating with fixed appliances to expand?
Not really. I haven't seen anything that jumps out at me that makes me concerned. And that's where I defer to the experts, and that's where I look at the literature. I am not going to expand, and I think if that's the question, I need to see some really good studies to show me that I'm going to get the expansion of a MARPE that I showed you, or a dome procedure using brackets and wires. I'm not concerned about buccal bone because I haven't seen literature to support that if I do it in a growing individual, we're all going to expand a 10-year-old or a 12-year-old, or at least most of us will. So I'm not really that worried about the expansion there. It's really helped me make better decisions, which is what this is all about, right? Treat a couple. I've had it now for over a year and a half, almost 2 years. And the more cases I treat, the more I can look back at and look and see what's going on. And again, it's been shown many times, and any of us who've practiced for a while know that the perio problems might show up 25 years from now. So when someone says, hey, I use this or that, and look, it worked out fine, not always true, because we don't know what's going to happen in 25 years. But it has helped me make a decision, particularly with those lower roots, when they're kind of tipped lingually, how I'm going to upright them. And if I do that with fixed or removable appliances, what's going to happen to the upper, and what do I need to do there?
Do you have your CT scans reviewed by a radiologist?
Never. Never. Well, never is a strong word, right? I've had maybe 4 of them read by a radiologist. So again, I want to reiterate, we need teams. We cannot practice alone. And it can't be a team where you send people your toughest cases all the time. They won't want to work with you. I send every airway patient to my ENT. I send every surgical case to my surgeon. I'm an advocate for, maxillary mandibular surgery, advancements, setbacks, whatever you need. So when I have a question about a case, I will share that CBCT with my oral surgeon, and they don't charge a penny, and they'll get back to me quickly, or I'll send it to my ENT. Why? Because we're part of a team. So when do I send it? When I take a picture of it or send it to my surgeon and he goes, this is not a patient who needs surgery. I was doing you a favor and I don't know what this is. And so that's maybe been a few times in a year and a half to 2 years. And when I do, I just tell the patient what it's going to cost to send it out and pass on the fee. I don't make money on it. I don't bill it out to an insurance. I just tell them and they pay, and that's the end of that.
I'm not sure if you mentioned this, but what software do you use to trace lateral cephs?
I don't. I don't trace lateral cephs anymore. I haven't traced a lateral ceph in 2 years. I just don't. My study, which you're bringing back painful memories for me, because I traced thousands of them, or had to measure them as well. We use Dolphin, which works great. That was my favorite program for that. So if you're going to trace, you can do it on a piece that we all learned, hopefully, on a piece of paper. Over it, you can trace it beautifully that way. The software shouldn't make a difference for you, though.
Cool. We have time for a couple more, but first, can you put your contact slide back up? We have a lot of people asking for
happy to.
That information.
And again, my practice is Krieger Orthodontics. If you ever want to go on there, it never hurts to like our page. I always appreciate it. And again, join Orthopreneurs if you're an orthodontist. It's not for teams, it's not for GPs. I'm sorry, but it is very ortho specific.
Do you have any suggestions on how or where to start to help reading and navigating CBCT images?
There's great courses out there, and I've no doubt that Henry Shining Cable can point you in the direction that works for them. Again, if you haven't figured it out with me, I'm a fan of getting information from everywhere. I drink from the fire hose. My greatest sort of teacher, the person I've learned the most from, is Sean Carlson. Polaris, which is the platform they've launched. You should go look it up. They're really developing something special for the ability to read and superimpose and evaluate CBCTs. I do have a limited stake in that company. I want to be upfront in disclosure, but it's so small relative to what they're doing, it shouldn't influence you. It's really great, called Polaris, and absolutely amazing tracking cases and getting the answers to some of the questions you're asking about fixed versus removable and what have you.
Can we use CBCT instead of 2D X-ray to avoid the exposure for radiation?
For what application, I guess, is the question. For restorative dentists, no. I think CBCT is like flying in a plane at 30,000 feet. You get a lay of the land, but I'm not going to diagnose decay from it. I'm not going to diagnose perio disease, from it. For ortho, absolutely. I mean, it takes the place of pan and ceph, absolutely.
And then had a couple questions about the different resolutions you took all your scans at. Would you mind quickly reviewing that?
The resolution at which I take the scans at?
Yes.
Yeah, I mean, it's 0.3 is what I take for pretty much everything. It's a 13 by 10 for the typical adult patient. But again, I don't take it at high res. I take it as a low res image, or standard res. I wouldn't call it low res. For a pedo, I think it's 16 by 13 centimeters with a 0.3 voxel size. That's what my typical scan is for low, what we call a low radiation one. The adult one is 3.7 seconds, and I think the pedo one is 2 seconds. Also a 13 by 16, I think it is. I apologize. The technical specs are not my thing, but I think that's the rough ballpark. It's 0.3.
Okay, then last question. Are you no longer taking cephs since every patient gets a 3D X-ray?
Yeah, there's no reason to. I take it, like I said, I used the Alara technique, right? As little as necessary, right? As reasonably accessible, or I forget the last A. But at the end of the day, my CBCT allows me to, pull out anything I need to see from it within reason for what I need for ortho. And are there times I send them to the oral surgeon and they need a higher res scan? Yes. But I always send every patient who gets a CBCT gets it sent to their general restorative doc, or the doc who's overseeing their care, and to the specialist to whom we're referring. So before they get there, they know exactly what's going on, and they can choose to take a better one if they want. And just so you know, I don't send anything. My TC sends it, and it takes her no more than truly 15 seconds, the way Anatomas shares it. It's really easy. And that's one of those workflows that's really made a difference for me. So great question.
Cool. Well, with that, I think we are out of time, so we'll wrap up. So thank you, Dr. Krieger, for your presentation today, and thank you, everyone, for attending today's webinar. As a reminder, if you did elect to receive CE credit for today's webinar, it is required that you complete the survey upon exiting the webinar. If you're viewing on your mobile device, the survey will not pop up for you, so please look for an email later today with that survey link. As a thank you for attending, everyone will receive a link to view the recording of today's presentation in the coming week via email. On behalf of Henry Schein and Cabo Imaging, thank you, Dr. Krieger, for an amazing webinar, and thanks once again to all of you for attending. Have a great rest of the day. Stay safe.